Good evening and welcome again. I'm Dr. Michael Duran, and tonight I'm here to talk to you about joint replacements, specifically some recent advancements over the past few years regarding navigation and robotic surgery. I think it's important first to start off with an understanding of what exactly arthritis is. I think a lot of patients ask this question when I see them in clinic, and it's generally an inflammation of the joint. It often causes pain, which is why patients end up in my office. There's multiple causes. The most common you hear about is osteoarthritis. There's also a rheumatoid, which is an immune-related arthritis, post-traumatic, or infectious. So when it comes to a joint replacement, what exactly is a joint replacement? These are some pictures here of some joint replacements. On the left, you'll see what is called a total hip arthroplasty or a total hip replacement. There's a cup with a polyethylene or plastic liner, and there's a ceramic head. That ceramic head attaches to the hip stem, which you'll see directly to the right of that. That goes inside the femur canal. On the right side, you'll see what are examples of total knee replacements. The femur or the thigh bone is replaced at the end where the cartilage is damaged by a metal prosthesis, and the tibia or the shin bone at the top part on the plateau is replaced by metal and plastic. Most surgeons often will also replace the underside of the patella, which articulates with the knee joint. So you ended up in an orthopedic surgeon's office. How did you end there? And why do you need a joint replacement? Well, as I tell all patients, they really determine when a joint replacement is necessary. And that is based off of a couple simple factors. It's based off pain and how the pain affects their quality of life overall. I often ask a lot of patients what activities are they no longer able to do, or how are they limiting themselves. The concerning ones that most often lead people to choose a joint replacement is when they no longer are able to perform activities of daily living. Activities of daily living are very simply doing hygiene, getting dressed, getting in and out of the shower. Beyond that, arthritis can also affect your ability to participate in your hobbies. Some people have to give up things like golf, or here in Arizona, pickleball is very common and popular. So I'll keep talking in general while we get this PowerPoint going about the progression of arthritis and how do we get to a joint replacement. So you're no longer able to tolerate your activities of daily living or participate in hobbies. You've lost the ability to enjoy your round of golf. These are reasons people often come to see me, and that generally related to lower extremity joint replacements, which we're talking about today, which are hip and knee replacements. So at that point, we talk about different treatment options that have now failed, which I will get into here in more detail. Again, we talked about how do we get to the joint replacement. We have progression of arthritis. Our standard conservative treatments are no longer effective. Those are the things you hear about, which are the anti-inflammatories, ibuprofen or Aleve, no longer providing any relief. We've tried our injections, all of those things, and it's continued to affect your quality of life. This is a brief synopsis over some treatment options which are recommended conservative or non-surgical treatments for arthritis. This, in this specific case of the knee, and this is from the American Association of Hip and Knee Surgeons, and this is as of this year. So as you can see, oral NSAIDs, anti-inflammatories like ibuprofen, have very strong recommendations, as does Tylenol or acetaminophen. Topical anti-inflammatories, diclofenac gel, which is now over the counter, you may have heard it called Voltaren gel, can also be effective and help with the pain. Supervised exercise programs are always beneficial. Self-management and patient education. I think if a patient's aware of their arthritis and aware of how it relates to them and how it affects them, it can often help them cope with the disease, and they may be able to do better without requiring surgery. Weight loss and canes or bracing have some moderate evidence. And again, one of the mainstays of our treatment options are our injections. Most commonly we use either corticosteroids or hyaluronic acid, gel, rooster comb as it's been called in the past. What about other treatments? I get asked this all the time about patients wanting to try turmeric or glucosamine chondroitin or ginger. While these treatments have limited evidence, patients sometimes do find them beneficial. I don't discourage treatment with these options, but I also don't prescribe these. If patients see some benefit in them, I don't tell them to necessarily stop using them. But in some cases, things that I'm strongly against is oral narcotics for pain control before surgery for a joint replacement. I'm seeing less and less of this as there becomes more awareness of narcotics and the dangers of narcotic use for chronic conditions like joint pain, arthritis. So again, strongly against using this as a conservative treatment to avoid surgery. So this is some radiographs as you saw at first. I showed the first slide, and this is a hip arthritis. On the left is a patient with left-sided hip arthritis. And again, as you look at these x-rays, on the right is actually the left hip. That's how we look at our x-rays. And on the right, the patient has maybe mild to moderate arthritis. You can see the difference in these x-rays, and I go through my x-rays with each patient on their visits. You can see a loss of the joint space. It looks kind of fuzzy. You don't see that nice, clean circle that you do see with the normal hip. And on the right of the screen, you do see after a replacement, the patient has had a total hip arthroplasty or a total hip replacement of their left hip. And in the difference in these slides, which is actually about 2 years apart, you can see a little bit of progression of arthritis in the right hip. It's lost a little bit of that smooth appearance to it. So this takes us to the overall background of how do we do our joint replacements. There are multiple ways, multiple different techniques to get to joint replacements of how you do the surgery, the approaches in the hip. People often get caught up in anterior versus posterior versus a lateral approach and the differences there. We're not going to talk about those in overall detail tonight. We'll talk about instead of how do we actually do the surgery and how is the navigated or robotic surgery different. Well, must first understand prosthesis design. Whenever we see a patient, we look at their x-rays, we look at their arthritis, and that determines sort of the prosthesis design. The prosthesis design is based somewhat off the patient's anatomy, and these different device companies have multiple variations of both hip and knee replacements, which we're able to adequately decide to use in certain situations for certain patients. When we go to the surgical planning, we look at the radiographs. We look at the x-rays, we look at the patient, we look at how their pain is attributed to their anatomy and their pathology, and then we come up with a surgical plan. On the right, you'll see a radiograph of a left hip again, and you'll see how we templated a potential hip replacement within the hip. And this is how we can make our surgical plan about where we want to make our bony cuts and remove the arthritic joint, and where we want to place the new prosthesis. So this is called templating, and this is a way we have done this for a long period of time. So the execution of the joint replacement based off how we position these joint replacements, and I'm talking in a non-navigated or non-robotic senses, we have jigs or cutting devices that we place during the surgery which help us remove the diseased bone. We use anatomic landmarks that we know of, which are very similar from patient to patient, and we try to build back the joint to a normal anatomy. We know that you lose a little bit of leg length, so those of you that have long-standing hip arthritis, you may feel like one leg's shorter than the other, and your body is kind of adapted to that. So we try to bring that anatomy back to normal, try to bring that leg length back out to normal. So that's part of our execution in building up a joint replacement. And also during surgery, we are always trialing and looking to balance these joints back to a normal anatomy. So before we even put in a joint replacement, we put in some trial implants, and we run through various ranges of motion and determine to make sure that the device is stable and that it fits what we plan to execute before surgery. And then at that point, we will determine to go with whatever trial implants we use and get the actual implants to put inside the patient. So what is robotic and navigated assisted surgery? Overall, it's very similar to the traditional approach that we take for surgery. Now, the key difference is we use different techniques and ways to get to the fact of getting your personal anatomy. So we get real-time feedback. We can know exactly where we're making our cuts of the diseased or dead bone, and we almost get a 3D representation using computer imaging to help provide our positioning and balancing. We can run the knee through ranges of motion with our navigated arrays on there, and that helps us to know exactly where the patient has some deficits, which we may be able to change a little bit of how we approach the surgery and how we approach the resection of the diseased bone and how we approach building back up with the new implants to adequately balance the joint we're taking out. I'm speaking broadly, not specifically of knees or hips, but in a general sense. So what does the robot add on top of navigation? Because they're both very similar. Well, the robot is essentially a navigated surgery, but we use the robot or a robotic arm to help remove the diseased bone or diseased tissue. So the robotic arm is calibrated to the patient's anatomy, and we use that to make sure we get very precise cuts to remove the diseased bone, and we can also very well balance the new inserts or implants we're putting in through ranges of motion. Here's an example of what a surgeon may be looking at on a computer screen while they're operating under your knee with navigated or computer robotic surgery. So after calibrating on the patient, you can see all those little dots there. Those are dots, are checkpoints that we take during the procedure when we map out your bone. So we've mapped out the femur, in this case of the patient, and the tibia. And then we run it through various ranges of motion. And you can see on the top we're getting degrees, and those degrees are calibrated to the mechanical axis or the axis of the patient relative to their anatomy. Varus and valgus are terms we use to describe like knock-kneed or bow-legged. Flexion extension, as you can imagine, the knee flexes and extends. So full extension is when your knee is straight out, and full flexion is when you're bent back as far as you can go. Internal and external rotation, that's, as you can imagine, a dimensional rotation of the knee itself. This is what it might look like on a sawbones or a fake set of bones when we place the navigated joint replacement arrays. Those arrays are using screws to screw in the arrays on both the tibia and the femur. We use these arrays to get real-time feedback as we're doing the surgery. This helps us to, again, remove diseased bone and for our implant insertion so we can get adequate balancing and match the pre-planned surgery we went for. So we make a plan ahead of time, just like we talked about before with templating and attempting for what we want to do to get the patient back balanced. We pick a size implant, we pick how we want to position it, and then we can use these arrays to give us real-time feedback that we've met what we expected to do. Here is an example of a robotic-assisted surgery. So we've done the navigation. You can see similarly on this patient, which is under those drapes and that orange film, which is Ioban, which is a impermeable antibiotic material. You can see the arrays with those white dots, and they're mounted on the femur and the tibia. And on the left of the surgeon there is that robotic arm. That robotic arm is giving him real-time feedback and calibrating his cuts to match what he planned or the planned surgery of this patient to give them the joint replacement we intend to give them. So when do I personally consider robotic-assisted surgery? Well, when I look at a patient with a severe deformity, and in this patient, these radiographs here on the right, you can see a patient that previously had a disease in their childhood which led them to have a deformed hip. That deformed hip has gone on to have severe arthritis, and the anatomy of that patient no longer matches normal sort of anatomy of a patient we see out on the streets. So the difference there is it's harder for me to rely on my anatomic landmarks to adequately position my femur and my acetabular or the cup component in the pelvis. So when I lose those anatomic landmarks, it helps to have a navigated or robotic-assisted surgery, which I can build off of a 3D CT scan, and we can make a better plan to put implants in this patient in a reliable and good position so they can have a good outcome. In cases of trauma, that is also have severe deformity. Congenital deformities, patients have hip dysplasia, things like that, where they have different anatomy than the normal patient with your run-of-the-mill osteoarthritis. So is robotic surgery better? Well, there's a lot of evidence right now and a lot of debate as whether or not it's cost effective. It takes longer. Is it better for the patient? And given that this is new technology, we don't have all the answers. What we do know is we are able to get more consistent execution. We get increased accuracy and precision of placing our implants. That leaves us with less radiographic outliers. We don't know if we have long-term data to show that this is better for every patient, but we do know that over time we get more consistent results. Complications. Is there a potential decrease in complications? In our partial knee replacements, we have seen some decrease in complications secondary to the advent of the robotic surgery. Is the surgical time increased? Yes, especially early on when you're integrating the robotics into your surgery, there's increased surgical time, but you're able to compensate for that in certain ways. Some surgeons have gone to cementless implants. Cementless implants require no cure time for the implantation of the device, so that decreases the time you're waiting for the cement to harden for the implants. So you do possibly save some time there because you feel so reliable about your cuts you're making in the OR that you feel more comfortable putting a cementless implant because you know your cuts are exactly where you intended them. Now, what about from a cost standpoint? There has been a cost increase of, some studies say, up to 20-25% increase in cost of total joint replacement because of the robot. Well, over time, we've seen in other industries, robotic surgery actually kind of even out or level out on cost effectiveness. And maybe we will see that in the future as we get more long-term studies when we see that we are actually seeing increased lifespan of these implants when the surgical time decreases. And over time, these robots, because there's a cost at the beginning of doing the beginning when you buy the robot or when a hospital purchases a robot, over time those costs should decrease. But more studies are needed. So that's a general synopsis of robotic assisted surgery and computer navigated surgery. I didn't want to get too in depth with you guys with the details, but I'll take any questions at this time. As a limb salvage specialist, my fellowship training is in musculoskeletal oncology. So we do a lot of limb salvage, especially for patients when we see with primary bone tumors, osteosarcomas, Ewing sarcomas. These tumors often have to be removed en bloc, so we sometimes remove joints or entire bones, and the goal of that is to remove a cancer from a person while salvaging their limb. So we often rebuild those with very large prosthesis, much larger and much more complex than the primary hip and knee replacements we're talking about today. Groin pain is very commonly one of the complaints of people that have hip arthritis. I often just get patients referred to me with hip pain, and I have to go through a whole algorithm of determining where this hip pain is coming from. There can be many sources of pain in the hip. Pain can come from, we call it trochanteric bursitis, or the IT band, which is the tissue that runs on the outside of the hip there, and that can be irritated, and we see that especially with women, because women have a wider pelvis in terms of bony anatomy, so they're more susceptible to this condition. Also, patients come in with hip pain, and they often point to their back of their hip. That hip pain can maybe be associated with another joint in the pelvis area called the sacroiliac joint, which is kind of where the spine meets the pelvis. Or it can possibly be associated with back issues. So often I'll see patients that come to me thinking they have hip pain. They don't have any hip issues within the hip joint itself, and it's actually maybe coming from their back. So as a clinician, that's something we got to tease out and find out exactly where the pain's coming from. On the same token, some patients have multiple areas of pain, and I'll educate them that, yeah, the hip might be bothering you, but we got to figure out what the main issue is and treat that first, and then proceed with secondary issues. If you've had a knee replacement or if you had a joint replacement, and for whatever reason, there can be various complex reasons that you would need a revision. We talk about revision arthroplasty. Most surgeons that do joint replacements also do revisions. They tend to be more complex because we have to remove the old components. So we got to remove the old hip replacement or remove the old knee replacement. In removing those, there's some bone loss. So we will do a revision knee replacement, meaning we take out the components of the knee you already have and put in a new knee replacement. Oftentimes, we're unable to do this with robotic assistance because you have so much bone loss that we go back to our old ways of doing things, which is when we use an intramedullary guide or other anatomic features. One caveat to that is sometimes we will convert people with partial knee replacements to a total knee replacement, and we are able to use navigated and robotic assisted technology for those. The recovery for a revision knee replacement is often a little longer because it's a bigger surgery than a primary, and often it's associated with some more risk of having stiffness and some complications. But often when these are done, they're necessary because you've either had a failed total knee for whatever reason, could have just been the lifespan of that knee has come to serve, or it could be infection, not infection, but loosening. That's something as a clinician we'll determine and discuss with the patient before we even talk about doing a revision joint replacement. Also, as a caveat to that, you may be having some pain and think you need a revision joint replacement, but you should probably seek an orthopedic surgeon because there may be some other issues where we don't even have to go down that road yet, and we can do some other conservative interventions before we consider doing a big procedure like that. Right away. So within the day of surgery, you will get up with physical therapy either that day or the next morning. Most of our patients are only staying in the hospital overnight, or possibly if we're doing surgery in the morning, a lot of the hip replacements will go home that evening. But they will get up with physical therapy, and they will start with physical therapy right away after their discharge. You will have a physical therapy plan before surgery, and you'll know. That's a good question, and this is a topic I have with patients that come in, and they often have severe arthritis and a BMI that is on the higher side. So I think a BMI above 45, it's a little, there's very little evidence to show that we should be doing these surgeries on people with that high of a BMI. Somewhere in the 40 to 45 is a gray zone, and then below 40, is generally not contraindicated, but we do like patients to be as fit and prepared for surgery as possible, so we like to have them optimized. And I think if you have the ability to lose weight before getting a joint replacement, it will be helpful to everybody. It makes it easier for the surgeon. It makes the surgery less complex. We can use a smaller incision. It's much less challenging for us to deal with the extra tissue. And then it's better for the patient, less infection risk, and less trauma, less of a surgical incision and surgery that the surgeon has to do. So I think in terms of preparing for a joint replacement, I always have a conversation with my patients to try to have them optimize as much as possible. The historical data shows us around 85 to 90% at that 15-year mark. That's a good question, and I wish I would have included that in my talk. So when we see patients and they have knee arthritis, I use the general term knee arthritis, but there are 3 compartments to the knee. So we talk about the medial compartment, which is the inside of the knee, which is the most common one we see arthritis. We also see the lateral compartment, or the outside of the knee. And then underneath the kneecap, the patellofemoral joint. Those are the 3 compartments of the knee. So when you talk about a partial knee replacement, you could be replacing any one of those components individually. The indications for that is that has to be the diseased part of the knee. So I would not do a partial knee replacement on someone with tricompartmental or arthritis throughout the whole knee. Also, patients with rheumatoid arthritis generally contraindicated for doing a partial knee replacement because rheumatoid arthritis affects the whole joint. So based off clinical exam and patient symptoms and how they're complaining, and we determine if a partial knee replacement is the best option for you. I think erring on the side of a partial knee replacement, if you have single compartment arthritis, is a good thing for the patients because we don't take out their ligaments like the anterior cruciate ligament or the ACL. And the PCL is sometimes removed for a lot of surgeons with a total knee replacement. So you maintain your normal knee kinematics, or your normal knee anatomy stays the same, and those ligaments are still doing their job, whereas in a total knee replacement, things like the ACL are completely removed, and we rely on plastic and metal to give you that stability that was previously done by a ligament. That's a good question. So the benefits for someone under 50, someone under 50, I really want to evaluate, are we really looking at needing a joint replacement? And there are people that do get joint replacements under 50. But the benefit of getting a partial knee replacement, if indicated with the patient, you have to have isolated arthritis in that area of the knee. If you have arthritis in the inside of the knee and the lateral side or the outside of the knee, but maybe it's worse on the inside, it's still questionable, and a lot of times contraindicated of doing a partial knee replacement because we know we have disease or we know we have arthritis elsewhere. So I would say the benefits of doing a partial knee replacement when indicated are that the patients will get more time with near normal or more normal kinematics, meaning the knee function, because the knee can be a very complex joint. So they'll get more time functioning with almost a normal anatomic knee as opposed to the knee replacement. That allows them probably to be more active and stay a little more active or at a higher level in the activities they enjoy. They may go on to get a total knee replacement later on, 10 years down the road, who knows, as they may develop arthritis in the other parts of the knee. And that conversion from a partial knee replacement to a total knee replacement is a lot simpler than going from total knee to revision total knee. And as I'll tell patients, doing a partial knee replacement is sometimes a good thing because we see, okay, you have a great result from the partial knee replacement. Awesome. Sometimes patients, they have maybe a partial knee replacement may seem indicated, and a lot of times I'll tell patients or educate them, hey, we'll talk about doing the partial knee replacement. If we get into the knee and it looks bad, I want you to know that we could possibly do a total knee replacement. And if we have that conversation beforehand, and if I see something that changes my approach, stop the procedure, talk to the family, say, hey, we talked to this person about possibly a total knee replacement. The partial does not look like a good option for them from what I'm seeing in the rest of the knee. So the gel injections are made of hyaluronic acid, whereas the knee steroid injection is a corticosteroid, which is an anti-inflammatory. The viscosity is much different in the gel injections. The goal, or people talk about kind of a lubrication effect. There is an anti-inflammatory effect as well in the gel injections. But overall, there are two different injection options we have for conservative treatment for osteoarthritis or for arthritis. So oftentimes I'll have patients that they've tried the steroids and they stopped working, so we move on. Maybe they want to try the gel injection, and we give that a chance. Or they've tried the gel and they go to the corticosteroids. So we try both options. A lot of times I think if you've failed a gel injection or you failed a corticosteroid injection, it's less likely the other injection is going to give you any relief, probably because you have at that point pretty severe arthritis. But we're always willing to try those conservative therapies with patients as long as they're willing to try. So we do talk about the formation of scar tissue. The biggest thing, especially, and let's talk about the knee replacements, that scar tissue can give people stiff knees. So the biggest thing for that is physical therapy, getting that range of motion, getting that knee moving. I always tell patients the biggest indicator of post-operative range of motion is preoperative range of motion. So if you have a pretty stiff knee beforehand, we're going to work to get you some range of motion, but that's my indicator that you might have a stiff knee afterwards. So we kind of deal with what we're dealt at the time of surgery, but scar tissue formation is a concern, especially with the knee replacements, and good physical therapy is key. Right, so the hip replacements, various different surgical approaches for the hip. It's hard for me to tell you exactly how big the incision is because the incision is generally dictated by a couple things, and that is the surgical approach and also the size of the patient. So patients that are a little larger tend to have larger incisions because it takes us more of an incision to get down to the hip joint. But I would just venture to say the incision is only as large as it needs to be. And again, with the navigated and robotic surgeries, you may have a couple extra incisions you notice. And that's because where we put the arrays in the tibia and in the femur, sometimes are outside of the surgical wound. So you might have a couple smaller incisions where we put those little screws in there to attach the arrays so we can get that real-time feedback. Again, I do see hip bursitis generally in my postmenopausal female population. One common complaint is it hurts to sleep on it, hurts to lay on that side. And they really point right to it, and they're very tender when you push on it. So my treatment recommendations there is physical therapy or home exercises. There are some good home exercise pamphlets out there. I give patient a home exercise pamphlet that they take each time that they come see me for something called trochanteric bursitis. Sometimes I'll do a cortisone injection, and often anti-inflammatories. One of the big things I tell people is get those foam rollers. A foam roller is a great thing to release that tissue on the outside of the thigh there. And that is really what's causing the issue, is it's tight. So a foam roller is definitely beneficial. Well, we know that age, older age is generally related to more complications in most of the surgeries we do. That doesn't mean to say that it's contraindicated or we don't operate on older patients and give them joint replacements. We know that as patients get older, they're more likely to have osteoporosis, which is going to be softer bone. So that does increase the risk for a fracture, whether that happens in the operating room or after surgery. And overall, the complications are increased for patients that are older, but we do offset those complications, again, with preoperative evaluation, and we have patients evaluated by their primary care physician, cardiologist, pulmonologist, to make sure they are fit for a surgery. And I think overall patients have great outcomes, even with those increased complications risk, as long as they're aware of what those are, and as long as we're aware as surgeons of what that means for us and how we should approach the surgery.